Hello, today we'll be talking about infective endocarditis, which is an infection of the heart. So here's an outline of what we will discuss today. I won't go through the entire outline, but we will progress basically from the pathophysiology all the way down to the treatment and to special populations that need to be considered during the treatment of infective endocarditis. So infective endocarditis, by definition, is an infection that involves some area of the heart. Typically, the valves of the heart are some of the most common areas that are involved, although the chambers and other areas of the heart can be involved as well. Now, although infective endocarditis is a relatively rare infection, it does cause a high degree of morbidity and mortality in patients that present with infective endocarditis. And for that reason, it's very important to understand the pathophysiology as well as the treatment course of infective endocarditis. Now, on the bottom right is a picture of a patient that succumbed to infective endocarditis that had mitral valve involvement, and you can see the extent of the vegetation and the destruction of the tissue associated with the heart. Infective endocarditis thus can be very devastating for patients that have it, and that makes the treatment course all that more important. So a little bit about the demographics of patients that present with infective endocarditis. Typically, these patients are over the age of 50, but an exception to this rule is that intravenous drug abusers tend to be younger patients, and they can often present with a right-sided infective endocarditis. In terms of the sex of the patient, men are twice as likely to present with infective endocarditis as women are. The risk factors for infective endocarditis are relatively straightforward. They involve things that have to do with structural changes to the heart or prosthetic devices that could increase the likeliness of seeding an infection in the heart. Being immunocompromised or having extended exposure to the healthcare system increases the likeliness of many types of infections. And intravenous drug abuse specifically does increase the risk of infective endocarditis in otherwise healthy young patients that would not have a predisposition for developing an infection in the heart. To diagnose infective endocarditis, typically the modified Duke criteria are the most commonly used diagnostic criteria. The two major criteria for the modified Duke criteria are first, positive blood cultures. Usually they have to be taken from multiple sites and at least 12 hours apart from one another, and the organism cultured from those blood samples must be consistent with one of the pathogens you would expect to be involved in an infective endocarditis. The second major criteria is an echocardiogram that is positive for infective endocarditis, and we'll talk about that in the following slide. And the minor criteria involve things such as fever, heart conditions, having vascular issues, immunological problems, some of which are kind of specific to infective endocarditis, such as things like Roth spots, which are retinal hemorrhages, or Osler nodes, which are lesions on the hands and feet, things like that. And lastly, if you culture organisms that are not consistent with what you'd expect for infective endocarditis, that would be considered a minor criterion. The combination of these major and minor criteria are used to ascertain the likeliness of a definitive or a possible infective endocarditis, and then the appropriate treatment modality will follow based on that diagnosis. So here is a figure taken straight from the IDSA guidelines on infective endocarditis. My students do not have to memorize this slide, but just be familiar with the concepts that are presented here, which is essentially that the transthoracic echocardiograph is the less invasive and less expensive version of imaging, and for that reason it is used when there is a lower suspicion for infective endocarditis, perhaps when it's done initially if it reveals features of an infective endocarditis, but there's no risk for complications. The clinicians may stop at the TTE, whereas the transesophageal echocardiograph is the more invasive procedure. It actually involves putting the imaging instrument down the patient's throat to get a better view of the heart, and because it's more invasive and more expensive, and because typically the patients can't eat for 6 hours up to the exam, they require things like local anesthetics and a sedative when the endoscope is being placed down their throats. The TTE is reserved for a higher likeliness of infective endocarditis, or when a higher resolution image is needed to ascertain the likeliness of certain complications with the infection. So let's now jump into the microbiology of what are actually the suspected pathogens in infective endocarditis and what would constitute a red flag for the major criteria on the DO criteria. So there are a lot of organisms on this slide, and that's because there is unfortunately kind of a wide range of organisms that are implicated in infective endocarditis. Now on the gram-positive side, we have things like strep. Now on strep, we have strep bovis, which is also known as Galelicus, and strep viridans. So this is one of the first times we've actually talked about strep viridans as a major pathogen. If you recall, strep viridans is a common colonizer in the oral cavity of patients, and for this reason there are implications with dental procedures and strep viridans, which we will discuss in the coming sections. Staphylococcus aureus, which is a pathogen that's responsible for many different types of infections, is implicated as well in infective endocarditis, and Staph aureus is particularly notable in intravenous drug abusers that are otherwise young and healthy but present with some type of infective endocarditis. Now the flip side of the Staphylococcus genus are the coagulase-negative staph, such as Staph epidermidis. In the past, the coagulase-negative staphylococci were more implicated in device-related infections because they had a proclivity for adhering to kind of that prosthetic device in the patient. But now there's considerable overlap between Staph aureus causing prosthetic valve infections and coagulase-negative staph causing native valve infections. And so the type of staph does not necessarily correlate with what type of valve is involved in the infection. So to close out the gram-positives, we have enterococci, less commonly seen than staphylococcus, but perhaps more frustrating to treat because of their kind of natural attenuation when it comes to the activity of beta-lactams. On the gram-negative side, we have this group of kind of strange gram-negatives we haven't really talked about in the past, which are the HAIC group, or HASHIC, or whatever acronym you prefer. These include Haemophilus, Aggregatibacter, Eikenella, which we talked about before as a pathogen in human bite infections, Cardiobacterium, and Kingella. So those pathogens you should be able to recognize as potential causative organisms in infective endocarditis. Now there's a long list of other organisms. Some are strange and hard to culture, some are just not very common, and you don't have to memorize those, but just be aware that there are many pathogens that are implicated in infective endocarditis. From the guidelines, you can see that the likeliness of a pathogen being implicated in endocarditis will depend on patient-specific factors, such as intravenous drug abuse, if the patient has any type of syndrome like AIDS, if they've had contact with animals, and if you have a specific patient that presents with a strange pathogen, you can consult different resources to try to determine which organism is the most likely cause of the endocarditis. So let's move on now to the antimicrobial treatment section. This will be the majority of the lecture and will be the most important things to study from when you're trying to understand infective endocarditis and the role that pharmacy has to play in the management of this disease. So, patients that have infective endocarditis will oftentimes require surgery. They will oftentimes have things like vegetations in their valves that will need to be removed. Perhaps they'll need to have a prosthetic valve implanted, or some type of operation that will remove the necrotic tissue in the heart. In general, infective endocarditis is a very hard bacterial infection to treat because the bacteria can exist at a very high inoculum inside the heart, oftentimes at inocula of 10 to the 8th or 100 million cells per ml. The bacteria can be in stationary phase, which makes cell wall active agents such as beta-lactams and vancomycin less active. And because the bacteria can exist in biofilms and in vegetations, it's difficult for the antimicrobials to actually reach the bacterial populations. And for this reason, prolonged treatment courses are normally required to make sure that all the bacteria are actually eradicated from the site of infection. And we'll see that the treatment course is typically on the range of weeks, ranging from at the earliest 2 weeks up to over 6 weeks of treatment. Because of the severity of infective endocarditis and the high risk for mortality in patients that are not adequately treated, typically patients that present with infective endocarditis will require an infectious diseases consult that will have some type of insight as to the empiric therapy based on patient-specific factors, the presentation of the patient, local pathogen resistance patterns, and other sets of information that will help inform the most optimized empiric therapy. Blood cultures are taken serially during the treatment course of infective endocarditis. Usually the first day of treatment will begin when the first blood culture is negative. That will be day 0 of whatever multi-week treatment course is recommended for that patient. So our first organisms that we'll look at are strep viridans. Remember, viridans group strep is actually a group of multiple types of strep, but they belong to kind of a similar grouping because they have similar presentations and similar characteristics. And strep bovis, again, that's also known as strep galeticus. So these two organisms, they do show up a decent amount in infective endocarditis, and for that reason, the guidelines kind of break down the most recommended treatment based on the MIC of these organisms to penicillin. So first, we're looking at the most susceptible version of these pathogens that you can encounter. They have a penicillin MIC less than 0.12. You do not need to remember that number. As we go through the next few slides, just kind of keep in mind the generalizations of these agents that are being used for strep. So we've said for other type of streptococcal infections, such as erysipelas, where you have group A strep, that natural penicillins are often the drug of choice. Here, for penicillin susceptible, highly susceptible pathogens, penicillin G is an option. Now that's penicillin G, not benxanthine, not procaine, which are different forms of penicillin. The other forms of penicillin can be intramuscular and have a slower release. For penicillin G, we want to have a very rapid attainment of our target concentrations, and that's why it'll be used for something severe like infective endocarditis. Now you have the option between penicillin G and the third generation cephalosporin ceftriaxone. Typically the treatment course would be for 4 weeks. Ceftriaxone may be preferred, as we know, because it's not renally eliminated in patients that have renal dysfunction. But because it is a third generation cephalosporin, the likeliness that it'll have activity against these pathogens may be higher than that of penicillin. So if a patient's not responding to penicillin, switching to ceftriaxone or empirically using ceftriaxone for older patients may be an appropriate decision. Now there is a caveat here, and that is that if you use penicillin G or ceftriaxone in combination with gentamicin, the treatment course can be shortened to 2 weeks, but the patients have to be healthy enough to qualify for this type of therapy. There shouldn't be any complications with their infective endocarditis, meaning that it should be something like native valve endocarditis without complicating factors. If they're responding rapidly to the treatment and they have proper renal function, that may support this type of aggressive 2-week treatment modality. So let's move on to the next group of pathogens, which are still strep viridans and bovis. Again, this is for native valve endocarditis, not prosthetic valve. And we're now looking at a slightly higher MIC, which is still considered susceptible, but the level of susceptibility is lower. Again, you do not need to memorize these MICs, just be aware of some of these treatment options we're using here. And again, we use penicillin G for 4 weeks, but now gentamicin is on board for 2 weeks, so combination therapy is recommended when the activity of penicillin is somewhat questionable. Keep in mind that the treatment course for gentamicin is shorter than that of the total therapy, so for the second half of the patient's therapy, they will not have gentamicin. Also note that for streptococcal species, gentamicin can be administered as a single dose. That means it's 3 mg per kg in 1 daily dose, whereas we'll see for things like Staph aureus and for enterococci, usually gentamicins in divided doses, typically 1 mg per kg Q8 hours. But the general idea is it's a 3 mg per kg daily regimen. For strep, it can be given all as one dose. For some of the more big gun guys like Staph aureus and enterococci, it'll be in divided doses. Now, an alternative to the combination therapy is to use ceftriaxone alone for 4 weeks. This, of course, would only be acceptable if the strains were susceptible to ceftriaxone. So our next group of strep here are the penicillin-resistant strep viridins, as well as some of these other weird pathogens, Abiotrophia defectiva and Granulicatella. Just be aware that the more resistant viridins group strep and some of these stranger guys have similar treatment modalities, which is now we're using combinations for the duration of treatment. You can use ampicillin or penicillin, which is in combination with gentamicin. This is somewhat reminiscent to the treatment modality used for enterococci, where we use ampicillin plus gentamicin. An alternative is to use ceftriaxone plus gentamicin, which would be appropriate in the setting of some type of penicillin or ampicillin high-level resistance. The duration of therapy will vary for these organisms. Keep in mind that the first day of treatment is when we first have a negative blood culture, and then they'll receive some type of treatment that may be 4 weeks or so, depending on the response of the patient. Now, everything we talked about up to this point for strep was native valve endocarditis. Native valve meaning it was causing an infection in the biological valve that the patient was born with. Now we're talking about prosthetic valves, as in they were surgically implanted in the patient's heart, and they have a artificial surface that may be able to seed the growth of bacteria perhaps more easily than the native tissue of a patient that has not had a surgical procedure on their heart. Now, for the reason that I just described, the treatment duration and the antimicrobials used for prosthetic valve endocarditis is oftentimes more aggressive. And so for prosthetic valves that involve strep, the treatment duration is now 6 weeks instead of 4 weeks. And you can see that we're using a combo for the first 2 weeks. When would you use the combination for the entire 6 weeks? Well, it would depend on the MICs of the organism and if it was responding in that 2-week period. Keep in mind that when we say gentamicin in combination, when you look at the susceptibility report, the organisms, because they're gram-positives, will oftentimes be resistant to gentamicin. But the susceptibility report itself can report high-dose gentamicin, and the susceptibility based on that higher than clinically achievable concentration of gentamicin will inform clinicians as to whether they can use it as a combination agent or not. So here are some other streptococci which have that are less commonly implicated in infective endocarditis, and because they're less commonly implicated, we won't spend too much time talking about them. The first being strep pneumo. Strep pneumoniae we have seen, or will see at least, in things like community-acquired pneumonia, and it has sometimes it will surface in infective endocarditis, although less so in comparison to something like strep bovis or viridins group staph. So for strep pneumoniae, you can start all the way from a natural penicillin and go up to a 3rd-generation cephalosporin based on the susceptibility of the strep pneumo and the local susceptibility patterns for that organism. Similar to the other strep, for native valve endocarditis, you would see a 4-week treatment course. For prosthetic valve, it would be 6 weeks. For strep pyogenes has been implicated in skin soft tissue infections, as we've discussed in the previous few lectures. Strep pyogenes can be treated with penicillin G, as it is oftentimes for skin soft tissue infections, or it can be treated with ceftriaxone. Again, the agent will depend on the strain of the strep pyogenes, and the treatment course will be based on the response to therapy and whether it's native or prosthetic valve. For other beta hemolytic strep, you can consider potentially adding gentamicin for 2 weeks, although that may not be necessary based on the patient's response to therapy. Usually these organisms require some type of ID consultation because they are less commonly seen and they require a more nuanced understanding of the local resistance pattern for these organisms. So here are the doses for treating these different streptococcal species. Again, penicillin G is the aqueous crystalline form. You will not use the long-acting forms that have lower peak concentrations. And so 24 million units, either given as a continuous infusion or in divided doses, is the recommended dose. Ceftriaxone I have in bold, 2 grams Q24. It's important to note that the dose of ceftriaxone here is half that of the dose used for enterococci, as we'll see later in the lecture. Typically, strep are much easier to treat than enterococci, and they're more susceptible to beta-lactam treatment. Gentamicin, 3 mg per kg Q24. As I said earlier, it can be given as a single dose for strep, whereas for staph and enterococci, it's usually given in divided doses. Ampicillin, also given as a high dose, 2 grams every 4 hours. For vancomycin therapy, because we're dealing with strep, you can target a trough that's relatively lower on the range of 10 to 15 micrograms per ml. Typically, vancomycin is reserved for penicillin-resistant strep or for patients that have severe beta-lactam allergies. So that was kind of a lot of information about streptococci. As I said, I don't expect you to know everything word for word, but do understand that Virden's group strep and strep bovis, which is also again known as Galelicus, are the two most common strep that are indicated in infective endocarditis. The treatment for these organisms is usually something with penicillin G or ceftriaxone. Again, don't use benzanthine or procaine. Whether you use gentamicin or not will depend on things like response to therapy, whether it's a prosthetic valve or a native valve, or whether you have a weird species of strep that isn't one of the two that I just mentioned. So the duration of therapy typically will be between 4 and 6 weeks, and vancomycin will be reserved for patients that have beta-lactam allergies, or if you're unfortunate enough to see a penicillin-resistant strain of strep. More typically, there would probably be something like strep pneumo, not so much strep bovis or Virden's group strep. So now let's move on to staphylococcal species. In the past, Staph aureus was the most important organism to focus on when it came to infections like skin soft tissue infections, but here for infective endocarditis, both Staphylococcus aureus and coagulase negative staph are important players when it comes to understanding infective endocarditis. As I said earlier, Staph aureus was typically associated with native valve endocarditis, whereas coagulase negative staph was associated with prosthetic valves, but those two niches are kind of overlapping with each other now, and we're seeing Staph aureus causing prosthetic valve infective endocarditis, and coagulase negative staphylococcus causing native valve endocarditis. So just because you see one organism or the other does not mean it's associated with a certain valve. Also, it's important to note that coagulase negative staphylococci are usually presumed to be methicillin resistant. About 50% of Staph aureus strains are methicillin resistant, but the prevalence of methicillin resistance in coagulase negative staphylococci is so high that we typically can assume that you can't use typical beta-lactam therapy for coagulase negative staphylococcus. So let's take a trip back to Bio 101 and take a look at the heart. When blood returns from the venous circulation into the right atrium, it is moved into the right ventricle through the tricuspid valve. It is then pumped into the pulmonary circulation through the pulmonary valve. So that blood was originally deoxygenated. It then goes through the pulmonary circulation. It returns to the left atrium. Will pass through the mitral valve into the left ventricle, and then the left ventricle will pump the blood out through the aortic valve to the aorta, where the oxygenated blood will then go on to perfuse all the tissues in the human body. So why are we talking about the heart? Well, the involvement of either the left side or the right side of the heart can have implications for how to treat infective endocarditis, where typically right-sided endocarditis has a higher likeliness of being less complicated, and potentially you'll see right-sided infective endocarditis in younger patients, potentially often intravenous drug abusers, who can have shorter durations of treatment, whereas left-sided infective endocarditis is a more difficult to treat infection and may require a longer treatment duration when it comes to Staphylococcus. So if you see mitral valve involvement, that would be indicative of a left-sided infective endocarditis, whereas something like the tricuspid valve would be a right-sided infective endocarditis. And distinguishing between native valve infective endocarditis and prosthetic valve is very important for Staphylococcus because the treatment modalities are very different depending on the nature of the valve itself, where prosthetic valves require aggressive combination therapy, and native valves oftentimes can receive monotherapy. So let's first look at Staphylococcus causing a native valve infective endocarditis. So as I just said, for native valves, the use of gentamicin or rifampin in combination with a cell wall active agent is not encouraged. In fact, some studies suggest that the use of gentamicin needlessly adds nephrotoxicity to the treatment modality, and thus combinations are not encouraged usually for native valve infective endocarditis. Now, as I said, the right-sided infective endocarditis is the easier of the two to treat, and if you do see right-sided infective endocarditis in an intravenous drug abuser, and the Staph aureus, in this case Staph aureus, is susceptible to methicillin, which means you can use beta-lactams. If those patients don't have things like mitral valve involvement, if there hasn't been kind of infection that spread past the heart, being pumped through the bloodstream, they don't have meningitis, they don't have issues with pulmonary circulation, and again, they don't have methicillin resistance, those would be patients that potentially qualify for an abridged 2-week therapy with a beta-lactam. Now, if the Staph aureus is methicillin resistant, if it involves the left side of the heart, if there are complications such as the spread of the infection to other areas like the CNS, the bone, and to the pulmonary circulation, that would require a longer treatment duration as well. And typically that's 6 weeks. So you can see there's a very striking difference in the treatment duration based on whether it's right-sided or left-sided, and based on whether the patient has complicating factors or not. So here are the doses you can use for either MSSA or MRSA and coagulase negative staph. For MSSA, similar to our other discussions about bugs and drugs, the first line agent is usually a penicillinase resistant penicillin, that is nafcillin or oxacillin. The dose is 2 grams q4 hours, similar to the ampicillin dose that we saw for streptococci. If you're worried about the patient having an allergy, you can use a skin test. One thing I will point out about these penicillinase-resistant penicillins is that if the patient has a brain abscess, that is a reason to use nafcillin or oxacillin over cefazolin. But cefazolin is also an option, given again as 2 grams, which is a common dose we're seeing for these beta-lactams, every 8 hours. It's a good option for patients that have relatively minor beta-lactam allergies, but you still want to have that highly bactericidal beta-lactam on board. Now, some students in class have asked me about the likeliness of having neutropenia when using certain beta-lactams. And the generalization is that neutropenia can be seen during beta-lactam treatments if the dose is high enough and the duration is long enough. So for relatively acute infections, where someone may receive a beta-lactam for a week at a mild dose, you usually don't need to be concerned with neutropenia. However, in patients that are receiving these 2-gram doses of beta-lactams for up to 6 weeks, that is when you may suspect a neutropenia, and so you should be monitoring the patient's white cell count throughout this therapy because that is a possibility. So if the Staph aureus is methicillin resistant, or again, if you have a strain of, say, Staph epidermidis, and you're going to presume that it's methicillin resistant, you can use vancomycin or daptomycin. The vancomycin trough, actually advocated by the endocarditis guidelines, suggests a trough of 10 to 20 micrograms per ml. I would personally say use a trough of 15 to 20, as other guidelines will recommend the more aggressive trough. For daptomycin, the manufacturer actually doesn't recommend going above 6 mg per kg Q24 because that is the highest dose that was used in clinical trials. But as we'll see, clinicians do go up to 12 milligrams per kilogram if need be. So the dose of 8 mg per kg, although it is high, it is not uncommon in the setting of very serious Staph aureus infections. Avoid clindamycin because the rates of relapse are higher than these agents. So, prosthetic valve infective endocarditis is a more serious infection that requires more aggressive therapy in the setting of having a staphylococcal prosthetic valve infective endocarditis. Essentially what we do now is we add rifampin to whatever the therapy is that we'd use for our native valve endocarditis. The therapy now is at least 6 weeks, but potentially longer, and gentamicin will be used for the first 2 weeks of therapy. So let's take a look at what that looks like on a timeline. If you look at the bottom of the screen, going out to about week 6, you can see we'll use one of the agents that we would use for a native valve endocarditis. That would be either a penicillinase-resistant penicillin, a first-generation cephalosporin, or vancomycin. We'll pair it with rifampin for the duration of that treatment course, which is at least 6 weeks, potentially longer. And then gentamicin will be used for the first 2 weeks. Now, as I said earlier, whereas gentamicin was given in a single dose for streptococcus, it's given in divided doses for both staphylococcus and enterococci. So here, gentamicin, the same daily dose of 3 mg per kg that we saw for strep, will now be divided into 2 or 3 doses. Let's move on now to the enterococci, which are very difficult to treat because of their natural ability to endure during beta-lactam treatment. So they're the third most likely cause of infective endocarditis, of which Enterococcus faecilis is by far and away the most common of the 2 pathogens. You don't see that much Enterococcus faecium during infective endocarditis. It is mostly fecalis. And as I've said many times now, beta-lactams that are typically able to cause bactericidal activity against other organisms may be static against enterococci. And it's for this reason that in this serious infection, we have to use combination therapy to try to optimize the pharmacodynamics of our antimicrobial regimen. So in monotherapy, you may see a beta-lactam only be static against enterococcus, but when you pair it with something like an aminoglycoside, you can potentially achieve bactericidal killing against the enterococci. So if the strain is susceptible to beta-lactams, typically you'll use something like ampicillin, and then ampicillin will be paired with gentamicin to try to achieve bactericidal activity. The exception to this, and the very odd scenario, and the only one to my knowledge when you actually use cephalosporins for enterococcus, is the use of ampicillin plus ceftriaxone. So we said during bugs and drugs that a class-wide effect of cephalosporins is that they do not have activity against enterococcus, and I said there's one exception. This is the exception. In kind of pilot studies where they paired ampicillin with lots of different agents to see what would improve killing of enterococcus, apparently the binding profile of ceftriaxone to these different penicillin binding proteins complements that of ampicillins in such a way that the two of them together can achieve additivity or synergy against enterococcus. So when would you choose ampicillin with gentamicin, and when would you choose ampicillin with ceftriaxone? Well, for one thing, if the patient's creatinine clearance is less than 50, because aminoglycosides are nephrotoxic, that would be one potential reason to try to use ampicillin plus ceftriaxone instead of gentamicin. Now, as I said earlier, the gentamicin susceptibility testing has to be done at higher than normal therapeutic concentrations. And if that in vitro testing reveals that even at high concentrations, gentamicin is not active against Enterococcus, that would be another reason to use ceftriaxone. Now, I did mention that the use of high dose and prolonged therapies with beta-lactams can cause neutropenia. So again, an ampicillin plus ceftriaxone regimen would probably merit having monitoring of the patient's white cell count as the therapy progressed. Similar to Staphylococcus, the gentamicin dose, which is the same 3 mg per kg daily dose we've seen this entire lecture, would now be divided in 2 or 3 doses, unlike strep, where it can be given as a single dose. The guidelines actually point out a target of a peak of 3 and a trough of less than 1, which would be pretty easy to achieve if you divide the dose. And lastly, the guidelines also mention a aminoglycoside called streptomycin. Streptomycin is a very old aminoglycoside, but its potential for causing nephrotoxicity is actually lower than that of gentamicin. And so it's possible that some institutions may actually prefer streptomycin as an aminoglycoside for synergy because it has less nephrotoxicity than that of gentamicin, but because it's so old and it's not in many formularies, it's not that widely used. So the duration of therapy for Enterococcus depends on how long the symptomatology has been present with the patient. If it's been less than 3 months since the patient has had symptoms of infective endocarditis, and keep in mind, those symptoms may be non-specific and it may not have occurred to anyone to try to find a source for the infection in the patient's heart, that would be an indication potentially for a 4-week treatment course. This is, of course, for a native valve infective endocarditis. Whereas if the symptoms last longer than 3 months, if you're using ampicillin plus ceftriaxone, which is the less studied of the 2 combinations we've talked about, or if it's a prosthetic valve, that means you want a treatment duration of at least 6 weeks, potentially even longer. So the dosing for vancomycin is relatively similar to what we've seen in the past, 15 mg per kg, Q12 hours. Again, you want to target a relatively high trough against Enterococcus. And if a patient actually has to use vancomycin because they have a strain of Enterococcus which is resistant to ampicillin, that would be another indication for using at least 6 weeks of therapy, potentially longer if it's a prosthetic valve. Now, if, God forbid, you encounter a strain of Enterococcus that is resistant to vancomycin, also known as vancomycin-resistant Enterococcus, or VRE for short, your 2 best options are linezolid, 600 mg Q12, the same dose we've used since Bugs and Drugs, or daptomycin. Now, if you recall, I said the daptomycin dose of 8 mg per kg when we talked about Staphylococcus was higher than the manufacturer's recommendation. Here we're going all the way up to 12 mg per kg, which is an extremely high dose of daptomycin. Still a Q24 hours, and both treatment modalities would be over a period of time that's greater than 6 weeks. So if you have a patient present with a vancomycin-resistant Enterococcus, your treatment options are very limited. You have to give them this very prolonged regimen that either consists of linezolid. Linezolid is associated with bone marrow suppression. It potentially can cause neuropathy, especially when given for a long period of time. And obviously you have to look out for drug-drug interactions like serotonin syndrome that may result the patients on something like an SSRI. And for daptomycin, of course, you want to get their creatine phosphokinase at baseline, monitor it throughout their therapy. This is an extremely high dose, 12 mg per kg. It's almost double what the manufacturer recommends. If the patient complains of muscle pain, recheck the CK, see if it's been elevated. That may be an indication for switching from daptomycin to something like linezolid. But again, this is a very bad scenario to be in. Typically, you want to be treating enterococcal infections with ampicillin plus either gent or ceftriaxone if possible. So here are the weird gram-negatives. I've changed the acronym now to HASHIC, kind of like the goalie who used to play for the Sabres. Those 5 organisms, again, that you should be able to identify are Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella, and Kingella. They do cause a minority of native valve infective endocarditis, but they show up enough that's important to be able to recognize them as potential pathogens on blood cultures that would count towards the major diagnostic criteria of the DO criteria. It is sometimes, though, difficult to culture the pathogens, but you can assume that they are resistant to ampicillin. In the past, ampicillin was used as the treatment of choice for some of these organisms, but the development of beta-lactamases from many of these strains has basically resulted in ampicillin being unreliable as a treatment option. And thus we use ceftriaxone, the 3rd generation cephalosporin. The dose is 2 grams IV IM Q24, whereas the dose for Enterococcus was 2 grams Q12. An alternative would be something like a quinolone or Unison, but those are just hypothetical alternatives. Stick with ceftriaxone as long as it's susceptible and unless the patient has some type of serious allergy that would preclude the use of ceftriaxone. The treatment duration is pretty straightforward: 4 weeks for native valve infective endocarditis, 6 weeks for prosthetic valve. Occasionally it's possible to see an infective endocarditis infection caused by a gram-negative that's not from that HASHIC group. It is relatively rare, and if it does happen, it would merit an infectious disease consult. These organisms, too, when they show up, oftentimes are multi-drug resistant. I remember one time when I was in Buffalo, one of the cardiology pharmacists came to my lab and asked what he should use to treat a Citrobacter endocarditis, and everyone was trying to scratch their heads and figure out how Citrobacter is seen an infection in the hearts. So these do show up, and when they do, it's very difficult to treat because of the lack of data supporting the treatment options for these different organisms. So in general, you want to use some type of combination. Beta-lactams are kind of the workhorse for all of these combination regimens, and so if it was Pseudomonas, you'd want an anti-Pseudomonal beta-lactam. If it was something like E. coli or Salmonella, you'd probably use a cephalosporin. And because there isn't that much data to support the optimal treatment duration, 6 weeks is usually a reasonable time to shoot for, but again, you want an infectious diseases consult, and you want to tailor the therapy to the organism and the patient's response. So there are times when the correct treatment is confounded by the lack of organisms that are cultured during the blood cultures that are taken for infective endocarditis. And so you may have positive imaging studies from the echocardiograms that show vegetation and things in the heart where you're unable to culture the organism. So there's a few reasons for why that may be. One is that if the patient received antibiotics prior to the culture, that will confound the negative cultures. If the organism is really stuck in a vegetation in the heart and the peripheral density is low in the blood, it may be difficult to grow. And there are some organisms that are just tricky to grow in general because their nutritional requirements make them fastidious and they're very hard to grow on traditional agar. So here's a list of some organisms that are difficult to culture. Some that should stick out to you are chlamydia and legionella, which we talked about as being intracellular pathogens that are very difficult to grow on traditional media. There are ways of detecting things like brucella as well. Candida and aspergillus are fungal pathogens that can sometimes cause infections in the heart. And so being aware of why the cultures may be negative can help inform as to how you should go about treating a culture-negative infective endocarditis. But obviously, if nothing's cultured, that means you're kind of shooting in the dark, and you much would prefer to have a positive culture, so you should do everything in your power to try to obtain positive cultures. So the following recommendations from the guidelines are all based on very weak evidence, and thus you do not have to memorize these. just be aware that for these weird pathogens that may show up due to culture negative infective endocarditis treatment, that you would use a combination, and the combination would be based on your best guess of what you think the organisms are that may be causing the infective endocarditis, but that you're unable to culture. So, for example, if you have a native valve infective endocarditis and the patient has an acute presentation, some of the most likely culprits that are not being cultured could be staph, strep, and some gram-negatives. So, vanco and cefepime may be a good option. If the patient has a native valve endocarditis and they have a longer presentation, now you may suspect things like enterococci or some of the Hashick organisms, and so perhaps using something like ampicillin sulbactam with vancomycin may be a better option. But again, this is just a tentative recommendation. It is not based on strong evidence. For prosthetic valves, the correct treatment is actually more obscure because now not only do we not know the organism, but because the patient has this synthetic device in their heart that can seed infections for lots of different organisms, it really complicates how you should go about treating the patient. So if they develop a prosthetic valve endocarditis within 1 year of getting the valve replacements, that means that there can be kind of a whole bunch of different organisms that got in there in that year. And so the empiric regimen, as you can see, is extremely broad. Vancomycin plus rifampin plus gentamicin plus cefepime is one recommendation from the guidelines, again, based on very weak evidence. You can see you're covering for many different organisms with this combination therapy, and you would want to de-escalate if you could potentially get a positive culture. And if you cannot get a positive culture, it really puts you in an awkward position for subjecting the patient to all these different antimicrobials. Vancomycin and gentamicin both be nephrotoxic. Rifampin having many drug interactions, it can increase the patient's LFTs, it can discolor their bodily fluids, and cefepime, those high-dose beta-lactams can cause things like neutropenia. So you want to be careful with the number of drugs you have the patient on. And from a stewardship perspective, it's terrible to have 4 drugs being used for a single infection. So it puts you in a very awkward spot as a physician. If they've had their symptoms for greater than a year, that means the likeliness that an organism got in there right after the valve replacement surgery is less likely, and perhaps you can use something that's less intense like vancomycin and ceftriaxone, but those are all hypothetical and will not show up on the exam. When it comes to fungal infections, Candida is the most common pathogen that will cause fungal infections in infective endocarditis. So Candida is a pretty common fungal pathogen in general. We haven't discussed fungal pathogens yet, so this will not be on the exam. And for these Candida infections, you actually use very big gun agents here, amphotericin B, which is kind of like the equivalent of vancomycin for fungal species. Amphotericin is sometimes called amphoterrible by patients because it causes stomach side effects that patients don't like. And flucytosine is a more minor agent that's used in combination with amphotericin for serious fungal infections such as meningitis, and in this case, infective endocarditis. So after the patient receives 6 weeks of therapy, they can be transitioned to a lifelong suppressive therapy with PO azoles. Azoles are well tolerated typically. They're given orally, and so it's not uncommon to see perhaps a use of amphotericin initially and then a transition to an azole antifungal. For fungal infections in general, the mortality rate is very high. Second to Candida, Aspergillus is actually the second most likely fungal pathogen. And because of the difficulty with culturing Aspergillus, sometimes that may actually be a cause of culture-negative infective endocarditis and may be suspected if a patient is not improving on broad-spectrum antibacterial agents. Now, for these fungal infections, in general, the patients do need to have surgical operation, and so it's not just unique to fungal infections, but you'll also see it in different infections, such as with when the patient has bacteremia that's persistent and it's not improving on the antibacterials, when there is recurrent prosthetic valve infections, when there's valve dysfunction or signs of heart failure, many different indications in infective endocarditis will require surgical interventions. And the surgical intervention that is made has to be done by a team of very specialized, well-trained surgeons that have specialized in cardiac surgery and are able to perform very nuanced surgery on what is one of the most vital organs of the entire body. And because of that, high barrier to entry in terms of the amount of training that's needed, it's hard to come across a very adept team that can perform these cardiac surgeries. And I have a clip here of a team performing a cardiac surgery, just a brief 30-second clip that I think really highlights the level of coordination and how meticulous they have to be when approaching the surgical operation.
I'll get it! We have precious little time left, people. We're gonna lose him soon.
Doctor, his heart stopped!
Let's get it out of there. We need to zap this, quick! Who's making a potato?
My bad, sir. I missed lunch.
Damn it, I'm not gonna lose this kid! Close him up. We've done all we can. The rest is up to God. Kenny? Kenny, can you hear me? How are you feeling, son? Great. Son, I have some bad news. We accidentally replaced your heart with a baked potato. You have about 3 seconds to live.
So in addition to ensuring that the microwave is clear of baked potatoes, it's also important to make sure that if a patient has a stroke secondary to what's going on with the infective endocarditis, which can see different types of coagulation problems that could be in the CNS or in other parts of the body, that the patient doesn't have any type of hemorrhage, which would be a contraindication for the surgical operation. But given this list, you can see that there are a kind of long list of reasons why patients require surgical interventions for infective endocarditis, and even if a patient receives prompt treatment with antimicrobials, sometimes surgical procedures are just inevitable given the nature of the bacterial density, the importance of preserving the physical structure of the heart, and also the need to perhaps replace the valve in some patients. Alright, moving along here. What was I talking about? Yeah, so anticoagulation. So anticoagulation is controversial for infective endocarditis because it hasn't been shown to improve outcomes in the past, but patients are predisposed to having these coagulation problems because, as I said, their heart is seeding a bacterial infection. They're oftentimes bacteremic and they have bacteria in their bloodstream, and there can be these changes in protein cascades and things like that from the presence of the bacteria. And so intuitively you would think anticoagulation is helpful, but there can actually be cases where it's disadvantageous to use anticoagulation. So that would be in the case of if a patient has a prosthetic valve and they have some type of CNS event, then you should not use anticoagulants for 2 weeks. In other scenarios, it's kind of ambiguous whether anticoagulation will help or hurt. I think probably most cases you'll see heparin or something used, just because independent of the fact that there are bacteria in the heart, that the patients are at an increased risk for clots anyway, so you probably will see heparin used, although there isn't that much data supporting the use of anticoagulation in these patients. And if a patient was not already on aspirin, there is really no evidence to suggest that you should initiate aspirin in the patients, although if they were already on aspirin for a different medical condition, it can be continued during the duration of the infective endocarditis treatment. So, can you treat patients with infective endocarditis as outpatients? The nuanced answer is yes, you can, but be very careful which patients you treat as outpatients. The logic behind treating someone with infective endocarditis as an outpatient is that these treatment durations are extremely long. And so if the patient's in the hospital for 6 weeks at a time, that is debilitating to the patient's life. That is a huge burden on the healthcare system. And if you can have the patient treated at home, potentially everyone will win because you'll decrease the expenditures related to that infection and also increase the quality of life of the patient. Now the problem is that because infective endocarditis is such a severe infection, and the likeliness of having complications is so high, you have to be very careful with which patients you actually can treat at home for infective endocarditis. Now, two of the most likely complications are the development of heart failure and also having some type of systemic emboli. So Be careful in patients that have, say, a lower ejection fraction, things like that, that would lead you to think they're having diminished heart function. If patients have some type of clotting issue, you would not want to send them home because those are complications that may arise outside of the hospital, and then it'll be very difficult to address. Now, it is most likely that you would see some type of systemic emboli within the first 2 weeks of therapy. So if a patient was receiving, say, a 6-week treatment duration, and 2 weeks into their treatment, they feel much better, and they've shown no signs of any type of clot risk or heart failure problem, that potentially may be one of the candidates you would want to try to treat at home. You would also want to make sure they have no abnormal neurological problems because, again, the bacteria can seed either a CNS infection or a stroke, and you want to make sure that they're cardiovascularly stable. So, having no fever, having negative blood cultures, those are the types of things you'd want to see in a patient before you'd send them home. But the big thing with sending patients home is that they require lots of follow-up. And so, if a patient's receiving antimicrobials daily, they would probably need to either coordinate with some type of home infusion clinic or some type of outpatient service with the hospital. A nurse should probably stop by regularly and collect labs from the patient because you want to monitor things like their serum creatinine, the white blood cell count. The nurse can also monitor for things like the development of, say, a catheter-related infection. And lastly, you probably want to have other clinicians visit the patient as well, assess the clinical status of the patient, make sure that they're improving, that no complications have arisen. And you can see that the level of follow-up has to be very rigorous, and that the patients that are sent home must be done so judiciously with the belief from the medical team that they're at a low risk for complications and that they can be managed as outpatients. So all patients that have infective endocarditis should receive a dental consult. That is because you have lots of different types of potential opportunistic pathogens in the oral cavity of your mouth. And when patients have poor oral hygiene, what actually happens is that the duration of transient bacteremias that emerge during the course of, say, brushing your teeth, flossing, things like that, will actually increase. And if you address their oral hygiene, the likeliness of an infective endocarditis recurrence is lower. So this is particularly true for the Viridans group strep. They are implicated in infections following dental procedures. And if you can address a patient's poor oral hygiene in the hospital, you can decrease the likeliness of having a recurrence of the infective endocarditis when they are sent home. So now let's briefly talk about prophylaxis for infective endocarditis. I think I only have one slide on this, and it's a very text-heavy slide. So the beginning of the slide basically just addresses what I said in the previous slide, which is that transient bacteremias form essentially on a daily basis, that the duration of which in a healthy individual will last on the order of seconds to minutes. And in the past, because these transient bacteremias did form during dental procedures, clinicians were very concerned that these transient bacteremias may seed infections in patients that are, say, immunocompromised, that have certain proclivities for developing an infection. But then this was reevaluated, and the logic didn't really hold up because the duration of the bacteremias that a patient would experience from everyday activities like brushing their teeth is actually much, much higher than the length of a bacteremia that they would experience from a dental procedure when you aggregate all the times that the patient brushes their teeth and flosses and eats food or whatever. And because of that, they changed the recommendations for who should receive prophylaxis for dental procedures. And so now, the only patients that really need to have prophylaxis during a dental procedure, the dental procedure itself would have to be one that could increase the likeliness of a bacteremia, so it'd have to involve somehow like their gum tissue or the deeper layers of the teeth. There would be patients that have prosthetic valves, because as we said, prosthetic valves can seed infections for different types of bacteria. If they've had previous infective endocarditis infections, if they have certain congenital heart diseases, there's a list in the IDSA guidelines. If you were unsure and you were asked by someone whether a patient needed to receive prophylaxis for a dental procedure, I would refer you to the list in the IDSA guidelines. And also heart transplant patients that have inflammation in their hearts, those would be patients that should receive prophylaxis for a dental procedure. Fortunately, the prophylaxis is extremely straightforward. It's 2 grams of amoxicillin PO. You give it within an hour of the procedure. If the patient has some type of beta-lactam allergy, alternatives include things like clindamycin as well as azithromycin. And if it's a minor allergy, potentially you can use cephalexin. But in general, amoxicillin is the most common one you'll see. But again, it's reserved for patients that actually have a higher risk for infective endocarditis. In general, patients don't need prophylaxis for other types of like surgical operations and things that would not already require prophylaxis for a normal patient. And because of that, you'll see that lots of the recommendations for how to prophylax for these patients will be cefazolin. As we said in the skin soft tissue infection lecture, cefazolin is the most common antimicrobial used for the prophylaxis of most surgeries. So let's end now by very briefly talking about what to do with patients that have implantable devices. So to distinguish from a prosthetic valve, we are talking about an electronic device that will actually function in some capacity to terminate arrhythmias or as a pacemaker or something of that nature. So here's a diagram kind of demonstrating the relative placement in space of, say, a pacemaker from where the heart is. And so it's important to note the pacemaker itself is located outside of the heart, and it has leads that go into the heart and can cause electrical stimulation of things like the sinoatrial node or whatever part of the heart that the pacemaker is connected to. These patients don't require dental prophylaxis. Remember, the patient populations that require prophylaxis are limited, and the guidelines have tried to restrict patients that actually receive prophylaxis during dental procedures. Now, for these implantable devices, by far and away the most common pathogens are coagulase-negative staphylococcus. And so we said that coagulase-negative staph used to be implicated as the staph that caused prosthetic valve infections, but now it causes both prosthetic valve and native valve infections. But for implantable devices, like pacemakers, coagulase-negative staph is actually the major pathogen. So when do you remove the pacemaker and when do you not remove it? If the infection is superficial and doesn't actually involve the device itself, so for example, if they had a surgical wound from the insertion of the pacemaker and they have a wound infection but the pacemaker itself is not infected, that would be a potential reason to leave the pacemaker in place. If the patient actually has it confirmed that the device itself is involved in the infection, then you must remove the device and the leads typically. If the patient has infective endocarditis or a valve that's involved in some type of infectious process, the leads from the pacemaker are extended into the heart. And because you don't want the leads to become contaminated, if you're going to say replace the pacemaker, typically you replace both the pacemaker and the leads of the device so that you remove all foreign objects during the treatment course of whether it be the device-related infection or the infective endocarditis. Also, I didn't mention that if they have a Staphylococcus bacteremia that is persistent and refractory to treatment, that would be a reason to potentially remove the pacemaker as well, because you don't want to kind of seed an infection for the Staphylococcus that's present in the bloodstream by having that foreign body present in the body. So the antimicrobials you use, they would be based on the pathogen. We said that coagulase-negative staph is common, so you'll probably see something like vancomycin pretty frequently. And the duration of therapy depends on whether it's just the device that's involved or if you're actually seeing something like infective endocarditis. So if the device itself is vegetated and you have kind of bacteria growing on the device itself, coagulase negative staph love to adhere to foreign devices found in patients. And if you take the device out and essentially remove the source of the infection, a 14-day treatment course can potentially be enough. What if there are sources of infection outside of the device, such as infective endocarditis, where you would see like the vegetation on a valve of the heart, but the device itself is not actually the thing seeding the infection? If they have septic thrombophlebitis, which means they have this inflammatory process in their veins with bacteria in their bloodstream. If they have osteomyelitis, so the bacteria are now in their bones, or persistent bacteremia, these all suggest essentially that the source of the infection was outside of the device itself. Removing the device is not sufficient for helping to clear the infection, and now the treatment duration is more similar to that of infective endocarditis. So some general rules about when to put the device back in. It's interesting to note that maybe about half, I think I might be misquoting that number, but somewhere in that range, of patients that have a device originally do not necessarily have to have a device re-implanted after the treatment of the infection, whether it's because the original condition has resolved or the patient is not pursuing a different treatment modality for whatever that pre-existing condition was. But patients should first be re-evaluated to even see if they need to have the device put back, or a new device I should say. If a new device is elected to be inserted, as I showed you in the original diagram where the pacemaker was located outside the heart, the location of the device should be different so that you don't end up seeding an infection in the same location. In all conditions, you want to wait until the blood cultures are negative for at least 72 hours, because if you put the device back in when the patient's bacteremic, then it's likely that they'll just seed another infection on the new device. If the patient actually has valve involvement, so they have a vegetation on their valve confirmed from an echocardiogram, that would be an indication to wait 2 weeks from the first negative blood culture. The reason being that if you put the leads back into the heart where the vegetation is, then the leads will become compromised and you'll end up having to remove the device again. And so you really want to make sure that when you place the new device in, you're not going to seed a new infection by giving bacteria a place to adhere to. So typically long-term suppressive therapy is not necessary if the device is removed. Long-term suppressive therapy is only pursued in patients that can't have their device removed. Oftentimes they're not willing to have their device removed because they're nearing the end of their life and they don't want to have the device removed and have to go through that surgical operation. So long-term suppressive therapy can be relatively short duration depending on the prognosis of the patient and the predicted number of quality adjusted life years that they have left to live. But if a patient does elect to not have their device removed, it's very difficult to actually clear the entire vegetation if the device itself is seeding the infection. And for that reason, they will require oftentimes long-term suppressive therapy, which you can imagine is poor for stewardship, and also it's difficult to suppress an infection for that long if you're still leaving the device in that's seeding the actual infection. Moving forward, patients that have these new devices installed will have to receive prophylaxis during their installation of the new device. And similar to the surgical prophylaxis we talked about during skin soft tissue infections, cefazolin can be the agent that's used. Vancomycin is used less commonly, both because of stewardship and because it's nephrotoxic, but it is an option based on the level of methicillin resistance in the area and if the patient has severe beta-lactam allergies. So to summarize what we talked about today, infective endocarditis is an infection of the heart. It's usually bacterial, but it sometimes can be fungal. You want to start off with broad coverage, oftentimes guided by an infectious diseases consult, then guide the therapy based on the pathogen. The duration of the therapy often depends on whether it's a native valve or prosthetic valve, as well as whether it's right-sided or left-sided. The location and the type of valve will also influence the type of therapy, where you see combination therapy is more common for things like prosthetic valves. And the typical treatment duration can range from 2 weeks for right-sided infective endocarditis in healthy young individuals that are intravenous drug abusers, potentially, to over 6 weeks for things like vancomycin-resistant enterococcus. So once we actually have the susceptibilities, we of course want to streamline therapy to maintain proper stewardship, and also to choose the agents that are most optimized against that specific pathogen. The IDSA guidelines do a pretty good job of identifying the recommended agents on a national level, and I tried to outline that for you today. But there will be variations based on different institutions and based on their understanding of their own patient population and the types of pathogens that those patients present with. And lastly, as I said before, if you have a culture-negative infective endocarditis, that is a very scary position to be in. It's a very tricky situation to deal with. And you basically have to use your best clinical judgment to try to ascertain what's going on with the patient and to treat that infection. So here is the Gran Torino slide to study for the exam. This is a loose summary of all the treatment modalities that I summarized today. There are exceptions to these rules, and I only had like 70 characters to try to abridge several slides worth of notes for each one of these, so don't use these as ultimate gospel, but they are kind of guidelines for what you should use for each organism depending on the type of valve and also the type of organism. So to very briefly go through this, for strep, usually we see penicillin G or ceftriaxone. You may use gentamicin, where for prosthetic valves you'll use it for 2 weeks during a 6-week treatment course. For the other organisms, it depends on their penicillin MICs, things like that, the type of streptococcus as well. For staphylococcus, if it's native valve, we do not use combinations. I have here 4 to 6 weeks, but really it can be 2 weeks even if it's right-sided, and if it's a young patient that has that's an intravenous drug abuser with no complications, that can potentially be 2 weeks. Whereas for complicated right side, native valve infective endocarditis, or left side, that would be a treatment duration of 6 weeks. For prosthetic valves, you have to use combinations of a cell wall active agent with rifampin for 6 weeks and gentamicin for 2 weeks. For enterococci, you always use combinations because the beta-lactams are unable to achieve cidal activity by themselves. That usually entails ampicillin plus either gentamicin or ceftriaxone. Ceftriaxone would be a good option if the patient has poor renal function, or if the gentamicin was non-susceptible even at the super therapeutic concentrations that are not achievable in patients. Vancomycin is reserved for patients that have beta-lactam allergies or for strains that are resistant to beta-lactams, and those would be treatment durations that last from 4 to 6 weeks, depending on whether you use ceftriaxone or ampicillin, or gentamicin rather, for the combination, or if you use something like vancomycin as well. For prosthetic valves, it's always at least 6 weeks of treatment, and again, your treatment modalities are pretty similar. For vancomycin-resistant enterococcus, the number of options is very limited. Linezolid and daptomycin are the 2 recommended options in the guidelines. Both modalities would have a duration that's above 6 weeks potentially. Remember to monitor for side effects for both those agents if you're using them for over 6 weeks. For the Hashick organisms, ceftriaxone is preferred. 4 weeks for native valve, 6 weeks for prosthetic valves. For the non-Hashick gram-negatives, it's basically your best guess. Typically, they're beta-lactam combinations, and they're used at long durations because there is not much data to support the ideal treatment. And lastly, if it's culture negative, you have to use these weird combination therapies that usually use vancomycin and some combination of other agents to try to cover for what you believe the most likely pathogens are. So what should you know for the exam and for your API rotations and for life? Please be able to at least identify all the pathogens on slide 9 that were in color. The ones that are in black, you do not have to necessarily be able to identify. Although coagulase negative staph, I should put in color probably because that's a big one. But know the Hashik organisms, strep bovis / gallicus, Verdens group strep, Staph aureus, Enterococci, those guys. Be able to identify the doses in bold. I don't think I would ever put a question on the exam that said which of the following is the correct dose for ampicillin, but you should be able to identify if a dose seems wrong. If in the multiple choice question I say which of the following is the correct treatment option, perhaps I'll put in a dose that's grossly wrong. So just be able to kind of get a feel for these doses. Remember, we used 2 grams of ceftriaxone Q24 for some of the easier to treat organisms like strep, but we saw it Q12 for things like enterococci. Daptomycin could be like 8 mg per kg for Staph aureus, but then we went up to 12 potentially for enterococci. So being aware of those differences I think is important. And the number one thing you should be able to do after this lecture is, in your mind, have a feel for what type of agent to use and for an approximate duration based on what's going on with the patient, what the pathogen is, and all the little pearls I talked about in this lecture. So for example, if someone had a prosthetic valve infection caused by enterococci that was ampicillin susceptible and high-dose gentamicin had activity against it, the patient had good renal function, then you could say, well, ampicillin plus gentamicin would be a good option for at least 6 weeks because it's a prosthetic valve infection. Whereas if it was, say, a native valve infection caused by strep bovis and it was penicillin susceptible, then potentially you can use like penicillin or ceftriaxone 4 weeks, something of that nature. So you don't have to know everything word for word, but just be able to kind of identify what would make sense based on the pathogen and the type of infection. And so with that, I thank you for your attention, and I will see those of you who come to class on Tuesday, where we will go over the, we'll probably do one set of cases and then some practice questions for the exam. So thank you.